So we've seen, and basically if you think back, the 49.4 points on that quality score there, it was made up with a 3, a 10, a 9, an 8, a 7, and a 5 type of scores. So this is not a score that you have to be perfect on all the measures you pick on, right? I got a 50 points out of 60 possible points, or out of 70 possible points in this case. And it converts over to a 42 points. So we're taking the score, the possible score for that category, the percent of that, and then multiplying that 71 by 60% because that's the weight on the category, and that turns into 42.6 points. We do the same for advancing care information. We did pretty good, 75%, but not perfect by any means. And on the improvement activities, because really everybody can get 40 points out of the improvement activities, we did really good. And we got to a score of 75.2. So like I said, if you have been doing PQRS and you've been doing meaningful use, there really is no reason you can't have a score of more than 70. We were not perfect on everything to get over this, right? We were okay, but it wasn't that hard. If you're excluded from ACI, then your weighting is different. The 85% on the quality, and should be 0% on the advancing care information because you don't even have a score there, and 15% on the improvement activities. So again, that's how it works. We already talked about this part, so I moved it. Okay, so you have in your documents here, you have a Word file on your computer, and you also have it on your paper document. It's a 2-pager, it looks like this, like you see there, okay? This document is designed for you to fill in and start to make your plan for how you're gonna deal with MIPS, because all of you are gonna go home and deal with all the rest of your life. You're gonna deal with your kids tonight and their school issues, and tomorrow you're gonna deal with all the crises about who didn't show up for work or whatever else in your practice. So I would recommend that you try to fill out this paper, these 2 pages, as much as you can based on our discussion today and what you're thinking right now about your MIPS plan and what makes sense for your practice, because in 3 weeks, when you finally get time to come up from your crises, you'll be able to pull it out and remember what you were thinking about at the time, right? So we have at the top, you can take from your clinician list, who are my eligible clinicians for MIPS, right? You made a list early on. Which ones are there? You can write that down here. Do you think after all of our discussion you're leaning toward group reporting or individual clinician reporting? Which one makes sense for your practice, your group? Maybe make some notes to yourself about why if you want to. List out the quality measures that you were able to kind of identify. I think I'm going to report these measures, or these are the ones I want to look into further. And then at the bottom, well, I think I'm going to report via my EHR or via registry or whatever. Okay? And some comments. And then on the next page, you've got if you have any hospital-based or non-patient-facing providers or PAs that aren't going to do ACI this year, you can write that here. Remember who can do it, who can't. And then you may have some priorities. When you look at your ACI scores under this new scoring system, you may say, you know, we're doing really poorly here. And that's something we could fix that and get a much better score if we just gave out more patient education information, which used to have a 20% threshold. We'll make that 100%, and you just move from 2 points to 10 points, and it wasn't very hard. You know, so where can you make your improvements that are pretty easy for you on that, so that you can start to train your staff and your physicians in what's needed. And then you can list your improvement activities. On the data that we gave you is the whole list of 93 improvement activities. You can read that. I have color-coded some of them green. They are the ones that most practices will find easy to do. So you can look for the green ones to start with and then go back and find others that apply to your group and your practice, because everybody's going to be a little different with that. But which ones are you kind of thinking you're going to use? And then and then if you're going to use different reporting periods, do you think maybe you'll do quality first and you're going to focus on that for May, June, and July, and then you're going to focus on your, or you want to do them all together? It would just help you a lot, I think, to do this and give you something you can either share with your providers or use to educate your providers if they weren't able to come today into all the different components.
And so just a couple of things to follow up with this last part is, if your EMR is reporting on your behalf for your doctors, a couple of things. Ask them, are you reporting via a registry, or are you reporting via a
RDA.
RDA. That's on one of the slides. So just that question needs to be asked via an email or a chat, so that they can respond to you in a written format, so that you know how to ask them for the information, because a QRDA is not readable. When you get a QRDA, you have no idea what it says. It's like just question marks and it's computerese. So makes sense to the computer, but not to human eyes. Okay, so if it's through a registry, then that information usually is in like an Excel format, so you can see it. You want to know what your EMR is reporting for your doctors. For example, if Dr. Smith has done all of their medication reconciliations in his practice, but it's not picking up in his eClinicalWorks software, and eClinicalWorks is guaranteeing that they are sending in his NIPS information.
They probably are.
They are sending it in.
What are they sending?
With a 0 under medication reconciliation. Now, is that eClinicalWorks' fault? Not really, because they are reporting what is in there. Is it their fault that it didn't pick up what he said? Yes, probably so. But that's why you've got to start looking at this stuff now. Don't start looking at it in September and then try to figure out how to get your EMR to work. Start looking at your 90 days now and see if it worked. And then you'll be done. Look, you'll have all of your information. You can be ready to report your 90 days and not think about it. Okay, don't really do that, because you need to look at it throughout the year, but you need to start looking at 90-day segments so that you can see what the gaps are, and that's where this plan will help you. It will help you know what you're looking for and how to complete the process and follow through. The last thing I'll say is, with the risk assessment, it is still a yes-no answer. There are several ways to get a HIPAA risk assessment. One is through your IT company. You probably already pay them a good bit, so try to get as much as you can for that money that you pay them. Ask them if they'll do a HIPAA assessment for you.
A HIPAA security risk assessment.
Yes, a HIPAA security risk assessment. That assessment needs to have documentation with it. That's not something that they say, yes, it's done. It needs to have documentation so that if someone came into your office and said, could I see your HIPAA assessment, you have something to provide them. Okay, that's number one. Number two is the EMR may provide you a risk assessment. You need documentation of that too, because when people come to your office, the HIPAA police is what I call them, when they come to your office, they don't want the phone number of your IT company. This is something that your practice has to have. So you need to have documentation of that. If you cannot get at those two places, CAAP does work with someone who does HIPAA assessments. It's $1,500, and that's a one-time, like they come out and do the assessment and provide you the manual, and then you can update that manual. We will notify you when it needs to be updated annually, and that can go on probably until the HIPAA rules change, and so they do change periodically, and then you have to have new assessments, but you don't need an assessment every year. You can update your old assessment once you have one done.
But you do need to document that you reviewed it, it is still accurate, and you made any changes that there are every year.
Yes, so you can update it each year after you actually have one. And you can come up with one, but you've got to put in the time to do it also. So there is a way for you to do it. It takes a lot of research and a lot of time. So there are people who have done it that way. I just wanted to let you know the resources that are out there, and you're welcome to email me or ask me today. And for anyone who can stay and work on some of these things, Jeannie and I are available to help and to work through any of the worksheets. I wanted to let the rest of you guys, I think she has just a little bit more, but when she's done, I wanted to let you guys go, the ones that didn't have your
Excel.
right, your computers and things like that.
Okay, great. I just want to wrap up that this is a transition year, so things are going to get harder in 2018. Don't forget that. We're going to come back and start adding in resource use or cost from Medicare side as a fourth category in next year. We talked about the 2015 certified EHR and the new measures in the ACI category. Remember, the quality measures are going to be for the full 12 months in 2018, meaning you need to be ready to go January 1st of 2018. You can't be sitting around like this in April saying, what are we going to report? What are we going to report? So you want to get that so it's a process and it's working smoothly in your practice this year so it just continues and you're ready to report for your whole 12 months of 2018 with good numbers. It's not in anything written down, but I do not believe that CMS is going to leave these improvement activities as simple and straightforward as they have made them. So that's going to get harder, probably not next year, but probably the year after. And then don't forget your penalties increase next year. So it's going to get harder and it's going to cost you more to fail on this. So use this year wisely, please. My last thing is, this is what CMS is thinking about. They are trying to change how providers are paid to focus on the value that the providers are providing to the patient. That's a hard thing to do, to measure value. And the way CMS decided that they should measure value is, are you improving results? Meaning, are you getting better clinical outcomes on your patients? And are you reducing cost to Medicare? Are we using less resources to get those better results? That's, if you think about it, that is the definition of value. What does it cost me and what do I get for it? Value is cost and outcome in this reference. And you see these things throughout the discussion. We've got one outcome measure that needs to be included if possible. If there isn't one, you get to use a high priority measure, but they're focusing on outcome. And then they think the way they're going to do that, the way everybody needs to do that, is by you focusing on patient engagement. You see the extra value put on the patient portal measure. You see the value based on exchanging information with referring physicians, right? Those are in the ACI stuff. They think it's important that you use technology to accomplish this end, and they think it's important that you have an improvement process, an ongoing process that you work through. Where are my problems? What am I doing to improve them? How did I do on that? What do I need to do next? It's a continuous process improvement. So you can see these concepts kind of throughout the whole MIPS program. This is where they started and how they came to develop this particular program. It is not perfect, and I guarantee you it will change over the coming years, but it's not going to go away. So that is all I have to say. I will take any general questions quickly, and then we should let folks go. Or if you'd like to stay around, I'm happy to talk with you individually or work with your individual measures.